Good afternoon, everybody, and welcome to the third Protect Our Province BC briefing on November 2nd. My name is Melody Ma. I am a community rapid testing advocate and a UBC Medical Laboratory Science alumna. I am your host for today. First, I would like to respectfully acknowledge that I am speaking from the ancestral stolen homelands of the Musqueam, Squamish, and Tsleil-Waututh peoples. Protect Our BC is a grassroots group of physicians, nurses, health scientists, health policy specialists, and community advocates. We are working together to help people in BC stay safe by sharing accurate information about the COVID BC pandemic in BC and advocating for evidence-based policies. Our ultimate goal is to end this pandemic. For today's briefing, we're advocating for rapid tests to be used in a more widely and accessible public health as a more widely used and accessible public health tool in BC. The federal government provided BC with over 3 million free rapid tests, but we've only used less than 10% of them. The rest are sitting in storage and some are due to expire soon. Other provinces across Canada, like Nova Scotia, are giving their citizens easy and affordable access to rapid tests. But for some reason, rapid tests remain elusive in BC. Slide, please. So why should we use rapid tests for BC? Number one, vaccines alone aren't enough to end the pandemic. Number two, testing helps us socialize, go to work, go to school more safely. Number three, testing helps us track who has COVID so we can track long-term effects like long COVID. And lastly, testing helps us detect and break chains of transmission. Today, we will see presentations from Dr. Dr Liang, Dr. Paul Tupper, and Dr. Lisa Barrett. They will be speaking on the following topics. One, why rapid tests are an effective public health tool. What are the different types of tests available? How does it compare to PCR? Second, how these tests can help protect people. And lastly, why rapid tests are currently underused in BC and why that has got to change. To start, I would like to introduce Dr. Liang. Dr. Liang is an infectious disease physician and medical microbiologist. He is a volunteer speaker for Protect Our Province BC and a member of Mass for Canada and an advocate for This Is Our Shot campaign. Welcome, Dr. Liang.
Thank you, Melody. Thanks for the opportunity to speak to you about my perspectives and perspectives that have been clearly demonstrated globally and across Canada on the utility of rapid tests. But I think that we first to understand it and clarify some of the misconceptions that have been either amplified incorrectly in the media in terms of myths associated with rapid antigen testing, but also clarify why it is so important that we utilize these tests as a public health tool. So firstly, I'm sure many of you are familiar with the traditional PCR test. And the PCR test is actually also called a RT-PCR, reverse transcriptase, because what this test does is, first of all, a sample is collected. And in the past, most of the testing sites had collected nasopharyngeal swabs, requiring infrastructure for testing, staff who are trained, as well as then a transport infrastructure to a centralized lab so that these tests could be performed on more advanced platforms. And while you're waiting, that test result could be hours if you're at an accessible site, for example, a hospital-based laboratory if someone's in hospital, or it can be up to several days if you're in a more remote area where there's going to be specimen transport time. What this PCR test allows us to do is it is considered the gold standard for a personal diagnostic test. And this type of test detects the genetic material, in this case, RNA, is converted to DNA to be a more stable form, and then amplified to produce a result. The result that people receive, and including physicians, are usually a positive RT-PCR or a negative result. However, at the back end of the laboratory, we also have additional information called cycle thresholds. And that's how many times does it take to amplify this genetic material before it's at a detectable level. And the higher the cycle threshold, it means that the original sample had lower volumes, lower amount of virus. Whereas if there's lots of virus in this original sample taken from the patient, you will have a very low cycle threshold or low CT value. So consider the RT-PCR a gold standard for personal diagnosis or a diagnostic test. Now let's compare that to a rapid antigen test. So these are tests that can either be done by someone else or could be performed at home. Rapid antigen tests have evolved now so that people can collect it through a swab in the nose without having to get back to the nasopharynx. This can be done easily, accessibly at home, and results are available quickly so that this provides an added piece of information for the individual that will have utility in different contexts. This type of test does not detect genetic material, and the rapid antigen tests, in contrast to PCR, detect the proteins of the virus. The most commonly used one, which we'll be discussing today a bit, is detecting the protein called the nucleocapsid protein of this virus, so that if there is sufficient virus in the sample, it'll be detected using these rapid antigen tests. Next slide, please. The user experience in testing is very important because anything that is considered a barrier to testing will ultimately decrease population uptake. And when we have a virus that is invisible, and until someone presents with symptoms significant enough to be tested, that means that there's going to be a lot of opportunities for transmission. So we need to really consider the user experience as one of the prime targets to optimize. And when we look at PCR testing, especially now in British Columbia, with many of the testing sites closed, it makes it difficult. People have to travel by car, by public transport to get to a testing site. Sometimes it takes hours to get there. People in some areas have to book a testing, and sometimes the testing is not available until days later, is what we've heard from some people, depending on where they are in this province. And then by the time they've received the test, they still have to wait for a result. And again, that could take days. Meanwhile, during those days that they're waiting for the result and not getting tested, if they are infectious, they've already contributed to secondary, tertiary chains of transmission. If we look at the rapid antigen test user experience, this is much more comfortable, accessible, and gives you a result in a short period of time so that the individual can act on this result. And we'll talk about what those actions mean. Next slide. The thing to remember about COVID is that there is a significant proportion of individuals who are causing transmission chains when they have no recognizable symptoms. And that may mean that they just have symptoms that are so mild that they can't recognize it, or it means that they may not have any symptoms that are recognizable, and they can be contributing to transmission. A recent paper just published a couple of days ago was a systematic review looking at the proportion of pre-symptomatic or asymptomatic transmission. And although there is quite a wide range in these studies that are looked at, I think the overall conclusion is that asymptomatic transmission is an important and the reason why this virus is so hard to control. Next slide. So, but before we talk about the testing and the utility and why it's useful, I think it's important to look back at this picture, which shows viral load or amount of virus on the y-axis, on the vertical axis, and on the horizontal x-axis, you see what happens with time. When individuals are first exposed to the virus and incubating, they may not have any detectable virus there. And that means they are not contributing to transmission. As virus increases during this pre-symptomatic or asymptomatic phase, it has to reach a certain threshold before they are likely to transmit. And this period of time eventually peaks very quickly and then also comes down very quickly as well when you have a very high viral load. And that is the part where people are mostly contributing to transmission and including super spreader events. That's one of the important factors in super spreading events which is how much virus a person is emitting into the environment. And so to capture this peak of infectivity, we have a very narrow window. And if we don't capture that window, it means that detecting a person afterwards, days later, after their ability to infect with a PCR test, means that you've lost a huge opportunity to isolate the individual, inform the individual that they're infectious so that they can change their behavior and not contribute to forward chains of transmission. Now, the PCR test is very good for all phases of this. It can detect the virus at very low levels, at very high levels, and also once a person is no longer infectious, this PCR test can still detect the virus. And the problem with this is that there's a long lag time, so that there are many individuals now who are going for PCR testing, being told that they have been diagnosed with COVID, yet they're already in the far end tail of the phase where they're no longer infectious. They're being isolated for 10 days, they're asymptomatic, so there's loss of productivity without any impact on the goal of reducing transmission. It does tell them that they have COVID-19 and confirms that they have had this infection, but it doesn't address the part about how can we reduce transmission chains by capturing the individual during the most infectious period if we allow for a testing system that can do frequent and rapid testing to change personal behavior. So with the rapid antigen test, what you're really getting is diagnosing people during this peak of the curve when they're the most infectious. Next slide. There are several myths of rapid antigen tests, and we've seen this all over the media in terms of descriptions about its accuracy. People have said that the tests are not accurate in asymptomatic individuals. It's important to note that symptoms does not coincide with necessarily the viral load or peak infectivity. Symptoms can occur after or during peak infectivity. And so this test, as it detects the protein of the virus, does not take into account whether someone has symptoms or not. The test only cares if there's enough virus to be detected using the rapid antigen test to infer from there that this person is most likely in their highest infectious potential phase. Next slide. The other myth is that these tests are less accurate than PCR tests. Well, this myth comes about because of misunderstanding of how these tests accuracies were derived. Traditionally, when we compare a diagnostic test to a gold standard, such as PCR, we have to compare its sensitivity, specificity. But we have to recognize that comparing rapid antigen tests and PCR tests really aren't great comparisons, because one is a diagnostic test and the other is a public health surveillance tool. If we truly want to compare PCR tests with rapid antigen tests, then we have to be asking the right question, meaning if the test goal is to determine if someone has ever been infected, then maybe PCR is better because it's going to capture you at a very low virus load or at the end of your infectious period for sometimes months. We've seen individuals who stay persistently positive for months, yet are no longer infectious because it's still just detecting the genetic material and not virus that can replicate. So if we ask the question, are rapid tests accurate in identifying infectious cases, then the answer is yes. These rapid antigen tests are much more accurate than PCR tests to tell us if someone is likely in their most infectious phase. So because of the rapidity and the ability to frequently use these tests in the right context, it enables us to diagnose people earlier and in the most important aspect, to decrease transmission. Next slide. I think Paul will speak to this a bit more about the accuracy, but if we look at sensitivity, these tests are very good at detecting people who are infectious. If someone is a super spreader, it probably has even it can detect 95 out of those 100 super spreaders. If someone is maybe 2 or 3 days into their illness, having a lower viral load, then of course it may not pick it up as well. But if someone has, for example, cycle thresholds of around 25, it's almost 100% of the time that'll be picked up. Next slide. People have also said this isn't specific enough and that there will be false positives. Of course, every test has false positives and false negatives. Even if this test is 99% specific, when you apply it to a large population, you're going to have false positives. But it's easy to deal with. If we have a false positive on an antigen test, do another antigen test. We're not relying purely on the antigen test to make a diagnosis. So positive antigen tests will get confirmed by PCR. And in our experience of confirming PCR, we have rarely found any false positives when this test is implemented and done correctly. Next slide. I'll briefly talk about our experience, at least the experience I've been involved in with teams back in December. At around November, December, the tests were available, but at that time through nasopharyngeal swabs. And because we weren't able to rapidly train enough people to do the nasopharyngeal swab testing, we were limited in terms of how many sites we could utilize these tests in, especially in long-term care facilities where there were many outbreaks. So what we did is we trained medical student volunteers in their 3rd and 4th year to how to properly perform a nasopharyngeal swab so that it minimizes discomfort and actually gets the swab at the right location. And we trained them to use these rapid tests. And then they were sent to volunteer in some of the long-term care facilities within Vancouver Coastal Health that agreed with this pilot. During the pilot, there were, of course, cases of healthcare workers detected, and every healthcare worker case that was detected as a potential aversion of an outbreak. In January and February of this year, there was acute care hospital outbreaks that I've been involved in. And because at that time, we still didn't have the nasal swabs that are currently available, we had to set up testing clinics at the hospital to test staff. And staff were tested regularly. And during this outbreak, we were able to identify asymptomatic staff that were contributing to onward chains of transmission. So being able to capture them quickly with rapid antigen tests and to pull them from work that day helped in decreasing the time in which they were exposing other individuals, either during break room periods or when they're caring for patients, even with the PPE that we were using. In a homeless shelter, we've seen homeless shelters in the Fraser Health area and the Vancouver Coastal Health experience outbreaks or clusters, and the use of these rapid antigen testing was very useful because in a shelter facility, people come and go, and they're not always available for testing. So this test allowed us to meet people where they were at when they were available for testing to help resolve the cluster of infections earlier. And finally, most recently in September and October this year, in both long-term care and acute care outbreaks, now that we have these rapid antigen tests available in nasal swab format, people can self-test with an instructional video. They know to do it before work during the outbreak setting so that they're not inadvertently coming to work having acquired the infection during the facility outbreak. And that helps us quickly detect healthcare workers who are positive, but also in long-term care facilities, the ability to do the rapid testing in the unit where we have the outbreak on residents on a daily basis also helps us to quickly identify those residents who are infectious and infected rather than waiting for them to develop symptoms which may be subtle or difficult to detect. So in all those different examples, we've been able to utilize these rapid tests effectively, but we've also seen globally that rapid tests can be used in a test to stay type of context or test to enable activity such as schools to even reduce the need to close schools if there is transmission just by making these tests available for students and their families. It could be used in outbreak settings, as I mentioned, but also many other contexts, which we'll hear about later on during this talk. Next slide. The last thing I want to talk about is at Fraser Health, a partnership that Melody and I were involved in along with Fraser Health and engaged communities is to distribute the tests to hotspots. So this type of cluster busting approach or delivering the tests where they're most needed to allow the community to easily test at home when the incidence of infection is high in their community. And this was very helpful because I think we've heard from the communities that this obviates the need for driving very long distances or taking public transport to very limited testing sites in their area. So I think this type of community empowerment that we'll hear about from the Nova Scotia experience, this helped inspire us to do the same. So I think it's been very effective, and we'll see some of the data coming out from this testing, community-based self-testing pretty soon. Thank you.
Thank you so much, Dr. Liang, for your presentation. Now we will hear from Dr. Paul Tupper, who is a professor of mathematics at Simon Fraser University. He is also a member of the BC COVID-19 modeling group. Welcome.
Thanks, Melody, and thanks for coming to hear us speak, everybody. Next slide, please. Our group has been involved in modeling rapid tests, which means we have a mathematical model for what we know about COVID and what we know about the efficacy of the tests. And that allows us to make predictions about what will happen in different scenarios and what are the situations where testing is valuable. So for example, last spring, we were interested in looking at rapid testing for long-term care. Of course, that's a situation where COVID is the most deadly. It's among the most elderly people. And as we know, there's several very tragic outbreaks in long-term care in BC over the months. And that was in the time before there were vaccines available. And so one thing we did was, well, the current plan was symptomatic screening. So before someone would come to long-term care, of course, they'd be asked if they had symptoms. But as Victor's discussed, COVID can spread without the person having symptoms. And so there was no screen on detecting asymptomatic infections. So rapid testing is a perfect tool for that situation. And we estimated that could have prevented about 50% of the infections that happened being brought in by staff, and likewise also for visitors. Fortunately now, long-term rapid testing is available in long-term care in BC, and that's really valuable. Next slide, please. Currently, we're not using rapid testing systematically in schools, and there's a couple of different ways that this could be used. So one way is test to stay. So currently, if you are in a classroom with someone who was believed to be infectious, only close contacts are told to isolate. And other students in the classroom may be told that they're exposed, but they won't be given any other instructions other than to monitor for symptoms. So one way we could deploy rapid tests is that when there's been an exposure in a classroom, we could, for example, get everyone in the class to do a rapid test, and those who test positive, then they would be asked to isolate and then go and get a confirmatory PCR test. So this is a I think quite a mild and sensible precaution that we could take, because we know that COVID is not only spread to close contacts; it can spread over a longer distance. Another approach that's being done in Germany is regular testing of whole classrooms. So this is a much more extensive use of it, but it has the advantage that you can detect exposures as early as possible. So our work on COVID transmission, one of the key things we find is because of the asymptotic transmission, a lot of interventions that only happen after symptoms develop are too slow. And so screening classrooms is one way. It's like as soon as somebody tests positive, then you can intervene and act quickly, and that can prevent clusters from developing. Next slide, please. There's another way that rapid tests could be used that currently is not very easily available in BC, is to protect vulnerable people in sort of one-off settings. So next slide, please. So one example I like to have is that I have an elderly mother, and say I have my grandchild, or sorry, my child and my mother, and I want them to meet for my mother's birthday. And currently this is allowed under current COVID restrictions. And so the reason this is allowed is that we think it's fairly safe. But is there a way that we could make it even safer? Well, one thing we could do is give me and my child a rapid test, and then if it tests positive, then we say, okay, we're not going to have this visit, we're going to cancel it. But if it's negative, then we go ahead with it. So there's two objections you could make. One is that it's not there's a possibility still that the test gives a false negative and that they're still infectious. My child is still infectious, and that's true. But if the situation is that I believe that the risk is low enough, cutting out 90% of the risk is a huge benefit. That reduces the risk by a huge factor. And on the other hand, there's also the risk of a false positive. But I think in this case, it's clear that okay, there's some chance that the test will give me a positive result and I'll cancel this event needlessly. But I think most people would say that that's well worthwhile. It's well worthwhile to have that tiny risk of a false result if I'm cutting down the risk of the event by such a large factor. Next slide, please. So currently, as we've mentioned, only less than 10% of the over 3 million rapid antigen tests that BC has have been used. And so it seems like I would argue that there's lots of situations where we could be using them that we're not. And so thanks very much. I'm done.
Thank you so much, Dr. Tupper. Finally, I want to introduce Dr. Lisa Barrett, who is a clinician, investigator, and infectious disease specialist at Dalhousie University's Department of Medicine. She was the pioneer of rapid testing programs for Nova Scotia. Dr. Barrett, it's a pleasure to have you here today. We've really been inspired and in awe of the rapid testing work that you've championed in Nova Scotia. It's, as Dr. Liang has said, it's been a great influence to the rapid tests community distribution project that Dr. Liang and I helped initiate in Fraser Health. So thank you so much for that. So to shed a little bit more light into what you're doing in Nova Scotia, can you tell us first a little bit more about how Nova Scotia is using rapid testing in the community and what your program is about?
Right. And so I'll say that I have been a champion and a push, but this is really the effort of literally thousands of people in Nova Scotia, both within public health, government, Nova Scotia Health Authority, and most importantly, community members. And I'm going to be very clear about that because this is not just a diagnostic test, as Dr. Liang has pointed out. This is a tool to be used for several things. One, public health surveillance in a formal way. Two, public health surveillance in an informal way. Three, diagnostics on some occasions, but also number four, a protection tool for individuals. And so self-testing has become a huge thing. And many people in Nova Scotia have taken that to heart to both get tested and be the people doing the testing. And that leads into how we use testing. I framed it in terms of no symptoms, some symptoms, and fully symptomatic, because we know that asymptomatic and limited symptoms is an area where there's a lot of spread, as Dr. Liang has pointed out very nicely. And that was where we knew that we had to be if we didn't want to just react, but also predict and limit small clusters and outbreaks as we went along. And although I talk about it in terms of symptoms, which sounds very medically, again, I will point out and emphasize that this is community-led and meant to be a tool of engagement as well as diagnostics for our communities. So we use these tests. We use them very early on in the setting where we had some of our earliest cases in wave 3 and in wave 2. And that included setting up shop and doing rapid tests in bars downtown when we knew that there was transmission and spread among some young folks. And we also knew that, humans are human. They've been locked down for a while and we weren't going to change that part. So why don't we get out there, find some tests, and then help people to interact and socialize more safely? And the hashtag Test to Protect has become a very important part of our community here. So we use rapid tests in social settings in order for people to be able to go out for the evening. Neg for the night was another of the slogans that we have had. However, that expanded very quickly. And in wave 3, we had widespread use of community rapid antigen tests that were not just asymptomatic, but they were also done by trained members of the community, not just medical professionals or medical professionals in training, high school students, real estate agents, librarians, random people were actually using these, were the people doing these tests after we had trained them. And in fact, their fidelity to doing a proper nasopharyngeal swab was probably better than some of our full-on medical professionals at some points. And that was a key core part of our community-led engagement. These community members organized themselves. They spread out around areas where there was community spread or limited community spread in order to provide people with an opportunity to regularly get tested without symptoms. And that then spread into more opportunities for people to get tested with rapid tests, both in between and at the beginning of waves. And I mentioned wave 3. In wave 3, we actually detected in the asymptomatic, highly infectious, but asymptomatic phase, about 20% of our early cases in wave 3, which allowed us to get to a peak and come back down very, very quickly, in addition to other public health measures. So it was a very valuable tool. We've used them in targeted outbreaks. We've used them now as part of a formal surveillance program in the workplace. And we've added in vulnerable sectors since about last spring as well. Shelters, public housing, and most recently universities and schools. And schools, they're being used in a way that is in urban areas where there's access to PCR for kids who are under 12, who are experiencing only 1 or 2 symptoms. They can use those for a initiation at home, figure out if they're positive or negative, and go to school. And in rural areas, if they have a drive of a couple of hours or more to get to PCR, they can use them in the symptomatic setting in order to determine if they're positive or negative without having to travel 2 days and have their parent off work. They're being used in the rural settings that way. So that's a lot of information, but the take-home message, a lot of engagement, a lot of community lead, 2 different forms, both as a diagnostic in that latest school symptomatic part that gets confirmed by PCR if positive, but also the generation of a massive amount of take-home self-tests. We've been repackaging PanBios as self-tests and letting people take them home and self-regulate the reporting process. And I end with that because that is a significant and different change from most notifiable and reportable illnesses, particularly respiratory illnesses in this country. And not legislatively impossible, just not done that often.
And so what has been the result in terms of self-reporting so far?
We don't have a great way of figuring that out. However, we do know that there have been many folks, probably under 100, but then our denominator of new cases is quite low here in this province. Over the course of the entire time that people have been taking tests home. And when I say tests home, we've probably distributed over 150,000 through the home testing streams, through takeaway testing streams. And we've had under 100, but most of the people have come forward and said, yep, I'm positive. And we've created so little panic about being a positive and destigmatizing it that I suspect most people do report if they get a positive result. They come forward, and we have a low threshold, low barrier system, no appointment needed to get a PCR test anywhere that we do distribution or actual administration of the rapid test. So very low barrier for anyone who's involved and is positive.
Thank you. Obviously, Nova Scotia has been a pioneer in rapid testing. What would you say to other provinces or other jurisdictions around the world that are lagging in rapid testing, like BC, in terms of what we can do and why rapid testing is, it's something really important to do?
I think control less as a government, control less as a health authority, control less as medical professionals, and build some trust and understanding with communities. We've coupled tests with vaccine opportunities, proof of vaccination opportunities, because the communities now trust us in some of the least trustful communities and populations out there, because we've offered opportunities for these people. We trust them. We say, go forth. And if you get a positive, we know you're going to do the right thing. I think that's a really important lesson that we're going to reflect on as we go through the pandemic and understand more. So just do it. Don't worry about having a perfect distribution system. don't worry, as has been pointed out by our previous two speakers, don't worry about the test sensitivity. It's 100% better than doing absolutely no tests in people who have no symptoms. Just do it and let people lead in the community. And I think you'll see the dividends go well beyond just diagnosis and testing to actual trust and involvement and engagement. And hopefully our vaccine mandates don't limit that, but that's my advice to everyone. Limit less, empower more. And I think we're going to reap the benefits of this, not just for COVID, but if we take it forward for other bloodborne pathogens that are asymptomatic, like HIV and Hep C as well.
Great. Thank you so much, Dr. Barrett, for your time today. Okay. So first of all, thank you to all of our speakers for their insights and advocacy on rapid testing, not just in BC, but throughout Canada. As we've heard, there's so many useful ways that BC can use rapid testing in schools, communities, and just everyday life. I mean, we've seen an example in Nova Scotia and how successful it's been and how the community has been very receptive to rapid testing. Our province needs to adopt a test and protect policy. And ultimately, what we need to do is make the 3 million rapid tests that are sitting in storage right now accessible and affordable to anybody who needs them. If you believe in rapid tests like we do, we encourage you to write to your MLA, write to Dr. Bonnie Henry, write to the your health authority's medical health officer to implore them to release the rapid tests for us to use. We need to get these rapid tests outside and out of these warehouses and into homes, into schools, and into communities. So now we will begin our question and answer portion of this briefing. So first, do we have journalists or? Okay, we are going to cut to Twitter questions that we have received from the general public. So first, if you had a choice to add another layer to vax mandates for large events, KF94 masks, I believe, or better, or rapid tests on entry and keep with poor partly worn masks, which would you choose? I guess this is one or the other, or yeah, one or the other. Did anybody want to take that first?
So I'll start. So we've seen how the tests can be used in large events. So there have been now randomized, like a large study in one I recall reading a while back is in Barcelona, where they had a large event with several thousand people going into a concert. They tested people prior to the concert, let them into the event, and during the concert, people could choose what they wanted to do. They could dance, they could sing, drink, they could keep masks on. It allowed people to make the choice, yet knowing that they've done an extra step prior to entering a place that is still probably considered high risk, being in a closed room, lots of people from different areas. So it gives people the additional information, and from that information, then people can make the choice whether they want another layer of protection. Because none of these layer interventions that we do, none of them are going to be 100%. So if we look from a safety science standpoint, as we talk about the layers of protection, the testing is another layer. We shouldn't compare necessarily and say that one is better than the other. I think all have their role, and when you have all of the tools that are available to you, some people may choose to use all of them, and others may just choose to use some of them. So I think this adds another opportunity for decreasing risk if people choose one or more of these interventions.
Great, thank you. We have a question from the media right now. Go ahead, Richard.
Hi, guys. Thank you all for doing this. Dr. Liang, I just want to get a sense from you about whether you think testing could help alleviate, some of the pressure we're seeing on the system right now. Like, as you're well aware, the hospitalization numbers continue to climb. We still have high death numbers. Like, how does testing turn itself into, alleviating that mounting pressure?
Mm-hmm. So I think that the pressure is on the system in multiple ways. From a hospital standpoint, I think most hospitals are at capacity. You see people waiting in emerge for beds. You see surgeries canceled. So from a immediate standpoint, testing will identify individuals early to enable the contact tracing system to be more effective. And Paul has published on this, so we might want to expand, is that if you look at the traditional contact tracing system that we use that relies on PCR, by the time someone gets a positive test, there's multiple chains of transmission already. And it makes it more difficult for contact tracers to get accurate information, both in terms of source of infection as well as those who are exposed. So it enables your test and trace system to be more efficient and effective, thereby reducing transmission. So in the longer term, it's going to help reduce the number of potential people coming into the hospital, overloading the system. In the shorter term, it also helps with some of the other aspects. We already see that testing sites require staff. These staff sometimes are deployed to these testing sites, yet have other skills that they could use to benefit the system in other ways. So if we want to resource allocate in a way that can bring resources to the areas most in need, then by doing rapid tests, not necessarily replacing PCR test, but as an augmented system, it may offload some of the pressure on the testing sites itself, and thereby freeing up staff, both in contact tracing and also in doing the testing in the laboratory and other parts of the system to refocus where they could provide the most value.
And if Paul wants to add there, I'm happy to hear it as always.
Oh, I agree with everything that Victor said. It's really, I mean, there's many synergies between rapid testing and contact tracing, as he said. Like, if we can detect COVID sooner, earlier, anything that helps contact tracing work better, and we can control transmission more. And yeah, I don't think there's any need. Sometimes it's painted that we're saying, oh, we shouldn't do PCR testing, we should do rapid testing instead. That's not it at all. It's the idea of doing rapid testing instead of nothing, which as Dr. Barrett says, is often in many situations what we're doing. Because if we have no way of detecting someone with COVID, if they don't have symptoms, then we're doing nothing. So we can do better than that.
Okay.
One other example, Richard, in the outbreak setting, where we're seeing outbreaks across the province now, whether it be long-term care or acute care, using these rapid tests for patients as well in that closed outbreak setting is an easy way to detect people quickly. Because if you want to put pressure on a system, you have an outbreak that's uncontrolled or poorly controlled, and any lag time in effectively controlling that outbreak is going to rapidly amplify the pressure on the system, because outbreaks, as we know, have huge pressure on both resources required, but also the number of people infected in a closed setting. So I think that outbreak use is really important.
Can I add a smidgen in there? You didn't ask me, but I'm going to
of course
in there anyway. To be clear, there is a tool you're not using if you don't use rapid tests to identify asymptomatic people when you're doing contact tracing. You're waiting till too far down the line, which is exactly what everyone's just said, but that's not living in fear to have people routinely testing during a wave in a general community where there's community spread. That is not living in fear. That is not getting on with it. That is not using the appropriate tools at your disposal acquired by your federal government to control a pandemic in the way that has been modeled to be effective. So just in case people were wondering, this is, in the case of a wave, willfully not using all the tools to get early identification. It's not living in fear.
Okay, thank you all very, very much.
Great, thank you so
Richard.
much. Okay, so next we have a question from CBC Radio Canada. Do the rapid tests sent by Ottawa have an expiration date?
Yes, so the all tests have expiration dates. So the manufacturers, it's on the box. You can see what the expiry date is. Some of the manufacturers have put out variance letters to extend the expiry date. And so all those letters have been delivered to people who are doing the distribution, to the governments across the country. as to what the new expiration date is based on those lot numbers that have been distributed. So it's been extended.
Thank you. Are there any other questions from Twitter? Okay, the next question. Can you please comment on BC's testing rate and how it compares to the rest of Canada? Can testing rates be compared easily?
I can comment on the first question and then maybe others. So in BC, the testing rate, you can track that both through our official platform, the provincial platform that's available, open access. There are some detailed issues that people should be aware of in terms of how much of it is public testing and how much of it is private testing, because sometimes it's been captured in those platforms as well. The federal government also has websites comparing the number of tests done on a daily basis. And what we've seen throughout the pandemic is BC does have a lower number of tests per capita than many other provinces. When it comes to comparison, I think I'm going to let Paul, Lisa, maybe answer about that.
I guess one way to look at it is what percentage of PCR tests that are done in the province are coming up positive. And I think if I recall correctly, it's around 5% now, and that's quite high. And that's one way to compare it with other regions, is if other regions have a lower positivity rate. But I'm not familiar with what the rate is, for example, in other provinces.
I think the thing that makes comparing testing rates difficult right now, for example, to compare Nova Scotia with other places, is that we do have a lot of self-testing going on. We have been promoting that, so we will be underestimating our denominator. So the lower number that we say are the number of people who have tested. We are underestimating that. So we're probably actually overestimating our percent positivity. And even then, we like to keep it below 1, not 5, from our perspective. So it does make it difficult as you enable and empower different populations of people to test, which is part of the challenge that people have always had with allowing that process to happen, right? Because then you have less of, you're probably not getting an accurate measure of how much virus may be around. On the other side, you're probably getting a more sensitive indication of the virus in your community. So although it's not controlled and only symptomatic, people have always said, oh, you don't need to know if people are positive if they're asymptomatic. They may not even spread to other people, which may be true in some viruses, but it's not true in this one. And it's part of the reason why self-tests are going to make the comparison across different provinces difficult, and also why it's probably a good thing, not a bad thing, to have self-tests. It's not, it may change the way you have a metric, but it's not a bad thing necessarily.
Thanks, Lisa. Dr. Barrett, I actually have a follow-up question for you. Do you know what the distribution rate is for rapid tests for Nova Scotia? So for example, in BC, we've distributed only 10% of the over 3 million tests that we were provided by the federal government. Yeah,
that's difficult because we've asked for more, and then we ask for more, and then we ask for more. So we always end up looking kind of low on everyone's like, oh, you've used X percent of the number you've asked for the federal supply. But we've asked for millions, and we're a province of 1 million people. And we've distributed well in, and I don't know the exact number. I was asking our folks a few minutes ago to send me the number, but it's into like close to 750,000. So that would be almost a test, like that's, 0.75 of a test per person in the province. And that's over a relatively short period of time, last November onward, that we were really using the rapid tests extensively after the university burst at the beginning of September 2020. So a lot is the answer. And the percentage we've asked for from the government, well, we've gone back and asked for more and more because we keep seeing opportunity to add on. And so our chief public health officer has been really great about enabling that process here in this province.
Great. Thank you so much, Dr. Barrett. So CBC also wants to ask a follow-up question. If there is an expiration date, how much time do we have left to use the ones we've been provided?
I would say that they can get a more accurate answer from the provincial distribution site. So in British Columbia, that is under the Provincial Health Services Authority. They will have the exact number that were distributed with the expiration date and the variants that letter that has gone out. So they'll be able to provide an accurate number. I can't give you that number based on what's available on the website.
Okay, great, thank you. Do we have any more questions? So here you go. This one is from Twitter. We've been told repeatedly by our public health officer that rapid tests provided by the federal government didn't meet standards. Did the maritime provinces get provided with different tests than us?
Well, I'll start, and then Dr. Liang, you had all the good stats on what the difference is in the accuracy and purposes of a test and what that implies. But I think no, we didn't get different tests here in the Maritimes, and in particular in Nova Scotia. We got the same tests everybody else got. Some provinces got slightly different ratios of some of the tests. But the take-home point is, of the ones, there's a small number that are now distributed that are LAMP tests, or they are rapid nucleic acid type tests. But almost all of the ones we have are rapid antigen tests. I think the problem was, again, we don't use them solely as diagnostic tools. They're tools of engagement and of surveillance, not meant for the sole and only purpose of diagnostics. But again, they are not bad tests. When compared with a gold standard, which asks a different question, they have a slightly different sensitivity in some populations, but that is mitigated in the way we use them, which is serial testing and not just once at one time point. And I think your slides, Dr. Liang, had really elegant answers to that at the beginning. But the take-home message is, the only question in the world is not the one that a regulatory body that does testing regulation in Health Canada actually asks. Some of the other questions are just as important, like, could you be positive, might you be positive, and then need a confirmatory test? And is this a tool of engagement for community? None of those tests and none of those questions were asked directly when these were regulated as diagnostic tests. So I think that's where the gap lies.
Yeah, and we've seen this in other parts of the world as well. Our neighbors in the States, Dr. Michael Mina has been advocating for over a year, and finally the Biden administration has released their new strategic plan, which includes deployment of rapid tests. But the reason for the delay partly has been regulatory bodies like the FDA and in Canada equivalent bodies, where they take a very structured way of looking at this and, as mentioned, may not be asking the right question within the set framework at which they've established it. So then they've conflated this purpose of the tool with a diagnostic test to then limit its applicability and thereby misinterpreted what people are calling standards. Standards need to be flexible. We need to recognize the urgency of the situation and be flexible to shift to our mindset as to how these tests should be working. And it's not about the sensitivity of the test itself, it's about the effective sensitivity of the testing system as a whole. And if we compare PCR versus rapid antigen tests, almost by all characteristics, except for that narrow characteristic of test sensitivity, rapid antigen tests beat out PCR in all aspects, not only economics, but also usability.
I have two follow-up questions. Dr. Barrett, you said testing is a tool of engagement. Could you expand a little bit on what you mean by a tool of engagement?
Yeah, I really hate, again, I hate it when I get into the asymptomatic, symptomatic, talking about this more as the diagnostic part of things. Nova Scotians, the minute we had a few cases, we had 38 cases today as opposed to our massive, usual 15. The numbers at our pop-up rapid testing sites and the number of takeaway tests that are distributed today will easily double. The minute people see a case number section go up, boom, people are out there testing themselves and having other people test them. And that's happened all the way along. So what I mean is we destigmatize testing as a medicalized event for a firm diagnostic and gave it to people and control to community members to actually organize the testing themselves too in places they wanted and needed. For example, in some of our newer to Canada populations and apartment areas, folks had very different ways they wanted to approach this, and they took it with them. So I think that's the other part, and people do the test more than once, and they learn to do it for themselves, and that's huge in community engagement. We didn't just tell people to stay home and do nothing during the pandemic. We said also get tested, which was an active, and human behavior loves an activity to do, right? Staying home and doing nothing is hard. Getting out and getting tested is an empowering thing. And I think we need to learn that more as we move forward with pandemic responses. And I love to say, I think this is the last one, but I don't think this is the last one. And we can't underestimate this. This cannot turn into a medical testing talk only. This has to be about people and behavior too.
Great. Thank you, Dr. Barrett. Dr. Liang, one clarification question. The province, BC, mentioned that there are tests that are waiting for Health Canada approval to be used in schools. Do we have to wait for those tests before testing could be implemented in school? What are your thoughts on that?
No, I don't see that legally you would have to, as long as you've set it up in the context in which it's clear what the purpose is. People are given the opportunity to be informed, educated, and aware of what the benefits are and what the limitations are. There shouldn't be any problems with implementing it now. I think some of the standards that people may be waiting for, I'm not sure if they're talking about the new tests that need formal diagnostic approvals, or this aspect of can it be self-performed, because they're not necessarily marketed in such a way.
Do you know specifically if there's a difference between the tests that are waiting for Health Canada approval that they want to use in school versus the ones that are approved right now?
I'm not sure. I haven't heard about which ones were wanting to trial in schools in British Columbia. I don't know if in other provinces there were.
Yeah, but the key message is that we have tests available. We can use them in schools. We're using them in Nova Scotia right now.
And in other provinces too, yeah.
Right.
I think this comes up to the off-label thing, because so the label refers to what the Health Canada regulatory agency for the purposes of a diagnostic test says can be used for this rapid antigen test. And then if you go off-label, which is, to be honest, most of what we do with most of anything and any drug we use in medicine too, PS, we go off label all the time because we're responsive to needs. So I suspect it's more a labeling issue than a new and different test that no one's ever heard of before, but they would have to check with, I think, Health Canada regulatory on that.
Okay, great. Last quick question. What are some good options for BC residents to acquire rapid tests at a reasonable price, preferably from a BC or Canadian business?
So residents who have like small businesses, they can apply through some of the official programs as a business entity. They need to meet certain requirements like number of employees, and then they could get it for free. Of course, that's not available to many people. Currently, I think the cheapest I've seen is through some distributors, and it shouldn't be around more than $10 per test if you could order a box. I think some of the distributors online do have a huge markup, and they were able to do that because of some of the delays governments have imposed, and as a result it's allowed for this kind of free market distribution, which makes it inaccessible for a large number of people in the population.
Great, thank you so much. Those were all the questions for today. So thank you everyone for tuning in to Protect Our Province BC's briefing on COVID-19 rapid testing. If you want further information on any of the topics that we've brought up so far, please visit our website, protectbc.ca. We thank you for your time, and we hope to see you at the next briefing. It will be on Wednesday, November 17th, and the topic will be on the impact of COVID on our hospitals and healthcare system. Visit the Protect Our BC website and social media accounts to confirm the time of the broadcast. We wish you well and stay safe. Thank you.